So today we're going to talk about cardiac syncope. My name is Usha Tedrow, and I'm the director of the Clinical Cardiac Electrophysiology Program at Brigham and Women's Hospital. Here are my disclosures. So when we see a patient with syncope, what are we worried about? Is there a risk of sudden death? Is there a risk of incapacitation? Is there a sign of serious underlying disease? Is further medical evaluation needed? Does it need to be emergent or immediate, or can it be done on an elective basis? The incidence of syncope is 6% per 10 years in a large retrospective evaluation from the Framingham Heart Study. The causes of syncope are listed here. An unknown cause was represented as 35% of the population. The 35% of the population also was felt to have a vasovagal or orthostatic origin. Only 9% of patients were truly determined to have a cardiac etiology of syncope, and other comprised another fifth of the population. Shown here is the incidence of syncope with each decade of life. So you can see that the incidence is fairly low in your 20s and 30s, but as patients age, as they're up to the 70s and 80s, the incidence of syncope can be quite significant. Shown here is the prognosis of different types of syncope. So shown here is vasovagal and other causes of syncope, or patients with no syncope here. And you can see that their survival over a long-term follow-up, nearly 25 years in some cases, is very similar to patients with no syncope. Those with cardiac causes, however, have the worst prognosis. Syncope can be a harbinger of sudden death, and sudden death is an important public health problem in the United States. There are more than 300,000 coronary artery sudden deaths in the United States per year, and 30,000 non-coronary artery disease sudden deaths in the US each year. Of the coronary artery disease population, about 150,000 are in patients that are known coronary artery disease, and in about 150,000, this is their first manifestation of coronary artery disease. So what are the cardiac causes of syncope that are associated with the risk of sudden death? There are arrhythmias that are associated with heart disease, ventricular tachycardia or severe bradycardia, obstruction to forward flow because of structural abnormalities such as aortic stenosis, hypertrophic cardiomyopathy, pulmonary emboli, or other more rare things such as tumors like atrial myxoma, aortic dissection, and then familial sudden death syndromes such as long QT syndrome, Brugada syndrome, and familial cardiomyopathy. What are the non-arrhythmic causes of syncope? There are reflex-mediated syncope, neurocardiogenic, vasovagal syncope, situational syncope, cough, micturition, defecation, which may have a neurocardiogenic mediator, orthostatic hypotension, hypoglycemia, and then, of course, a diagnosis of exclusion, but conversion reaction or psychiatric is possible. Initial evaluation includes a history, physical examination, electrocardiogram, and the purpose of all of this is to get a history of the event and also to detect occult heart disease. The history should include the patient's report, the situation, the provocative factors, whether they were postural or exertional syncope, distinction between a mechanical fall, vertigo, orthostatic hypotension, and true syncope. Also, a history of whether there was head trauma is important because that can affect retrograde memory of the events. Eyewitness reports are very important because the patient may not be able to tell a detailed account of every aspect of the event. Motor activity can occur with cerebral anoxia or with seizures, so it's not a perfect distinguisher between a seizure event and cerebral anoxia from an arrhythmia. A careful history of the event is extremely important. Features that are worrisome for a cardiac cause include the absence of a prodrome, so unheralded syncope, preceding palpitations or chest pain, syncope during exertion as opposed to right after exertion, blurred vision, Reassuring features that suggest a non-arrhythmic cause include repeated episodes over more than 4 years, features typical of reflex-mediated syncope, such as provocative factor, drawing blood, seeing blood, nausea during recovery, typical of an orthostatic hypotensive episode occurring on standing quickly in a susceptible patient. Syncope history, past history. So factors associated with increased risk include known history of heart disease, a history of myocardial infarction, bypass surgery, angioplasty, cardiac medications, an abnormal electrocardiogram. And then risk factors for coronary artery disease, including age, hypertension, diabetes, smoking, lipids, family history. And a detailed family history of sudden death is very important in terms of assessing risk. Drugs that can cause syncope include antihypertensive agents that are listed here, bradycardia from beta blockers, calcium channel blockers, digoxin, and antiarrhythmic drugs, hypoglycemic agents, hypnotics, which include ropinirole and gabapentin that are used to treat neurologic conditions. Illicit drugs and alcohol use can be important causes of syncope. Other drugs that can cause syncope are drugs that are associated with QT interval prolongation causing polymorphic VT or torsade de pointe. Antiarrhythmic drugs such as sotalol, difetilide, quinidine, procainamide, disopyramide, and amiodarone are causes. Psychotropic medications can also prolong the QT interval. Certain antibiotics, methadone, protease inhibitors, and there's a website that's maintained by the University of Arizona called credible-meds.org that keeps a running list of medications that can cause QT interval prolongation and torsade de pointe. So the guidelines propose a workup for the patient with syncope. So you have a patient with syncope, you do a history, physical examination, and an ECG. And if it's felt that the history and all of that simple workup is diagnostic for either orthostatic hypotension or neurocardiogenic syncope, you can stop there. However, if the patient has unexplained syncope, you would proceed to a structural workup, including an echocardiogram, an exercise test, and ischemia evaluation as appropriate. So in those patients, you would treat ischemia and structural heart disease as appropriate, consider defibrillator implantation if the ejection fraction is less than 35%, as per the guidelines for ICD implantation, and consider EP study for diagnosis in this population. However, if this evaluation is normal, then we have unexplained syncope, no noted heart disease, and we group the workup by how often the episodes occur. For a first episode, you could just follow along and see what the natural history of this is going to be, unless it's a very severe episode. If there are infrequent episodes, we would use an implantable loop recorder, which is a small device that can be implanted under the skin, battery life typically in the 2 to 3 year range, and that can monitor for rare episodes that occur once a year or once every 2 years, and help to make a diagnosis. Then more frequent episodes, you can correlate symptoms with an event monitor or ambulatory ECG. And at this point, you would treat an uncovered arrhythmia as appropriate, but if there's sinus rhythm that's demonstrated during an episode, a cardiac evaluation is complete. And I think that we can't emphasize enough that there needs to be monitoring during an episode, because a Holter monitor for 24 hours, for example, where no event occurs, doesn't really rule out any arrhythmic cause of syncope. So the ECG after syncope in cardiac patients is abnormal in about 30%, but diagnostic in less than 10%. Things to look for include bradyarrhythmias, ventricular tachycardia or frequent ventricular ectopy, acute MI. You can see markers for underlying disease, evidence of old myocardial infarction, Wolff-Parkinson-White syndrome, Brugada syndrome with ST elevation seen in V1, 2, and 3, hypertrophic cardiomyopathy with left ventricular ventricular hypertrophy, arrhythmogenic right ventricular dysplasia or cardiomyopathy. You can often see T-wave inversions in V1 through V3. You may see an epsilon wave. And then long QT syndrome with prolongation of the QT interval. Here are some brief examples of bradycardia that you might see. Here's sinus bradycardia. This could be normal in a young athletic person, but in an elderly person it might be a sign of sinus node dysfunction. This is not necessarily an etiology of syncope by itself, but it might point to sinus node dysfunction as a possible etiology. Here's an example of Mobitz 1 heart block where you see the PR interval is getting longer, longer, and then dropped. And normal again, and then longer again. This is usually due to delay in the AV node. It's not necessarily an urgent need for a pacemaker implant, but this could be symptomatic enough to cause a patient some dyspnea, and so further monitoring to look for higher grade heart block might be indicated. Mobitz 2 heart block is shown here, where we have a P wave and a PR interval, QRS complex. The QRS is a bit broad. The PR interval here is the same, with the same broad QRS. The P wave here is on time and then blocks to the ventricle. This is usually a sign of disease below the AV node, so unreliable conduction to the ventricle, and this could easily be a cause of syncope because there may be higher grade AV block at other times, and this is sufficient evidence to suggest bradycardia as the etiology, and a pacemaker would be indicated. When interpreting a strip like this, it's important to show that this P wave is on time because the most common cause for pseudo Mobitz 2 heart block is actually premature atrial beats that block when they come a bit early in the T wave. So if this P wave does not come on time, you can't diagnose Mobitz 2 heart block. And then lastly, it's no surprise that if you see complete AV block with P waves marching along and QRS is marching along at another heart rate, that could be easily a cause for syncope. So both of these last two scenarios would be an indication for a pacemaker. A quick word about neurocardiogenic or vasovagal syncope. We all know that there could be a prodrome with sweating and anxiety. There's often a stimulus, a noxious stimulus, whether it's pain or fear. And then there's sympathetic activation. Then there's increased cardiac contraction with an underfilled ventricle, stimulation of mechanoreceptors in the ventricle, and then sympathetic withdrawal with vagal activation. You can get two-component reaction of vasodilation and bradycardia. So this is called cardioinhibitory and vasodilatory, these two different parts of the reaction. And then there's hypotension and syncope. The patient clinically usually has yawning, nausea, and pallor. They can even have a little bit of tonic-clonic movements when they fall to the ground, but usually the symptoms resolve once the patient is horizontal on the ground after a syncopal episode. Neurally mediated syncope includes a bunch of different diseases. There's situational syncope, including micturition, defecation, swallow, and cough. There's also carotid sinus syncope, where people have carotid sinus hypersensitivity, vasodilator syncope, emotional faint due to stress, and then volume depletion or orthostasis. Here's an example of a tilt table response with a strongly cardioinhibitory component. It's hard to look at this kind of bradycardia and think that the patient doesn't need a pacemaker, but they often have vasodilation as well, and they don't necessarily need to have a pacemaker to resolve their episodes. Tilt table testing has sensitivity in the 67 to 83% range and specificity of 85 to 95% in some studies. Reproducibility is 62 to 80% over 3 to 7 days. Tilt table testing by itself is not usually required to establish the diagnosis, but it's useful in selected difficult cases to make the diagnosis. Therapy for neurocardiogenic syncope includes education, so to avoid triggers, and methods to abort episodes, including sitting or laying down, clenching of fists to try to avoid some of the vasodilatation, removing aggravating factors like dehydration, hydration, salt supplementation, fludrocortisone supplementation, Postural training, so tilt training can sometimes be helpful. Beta blockers, some patients will respond, but some patients will not respond to this therapy, and there's mixed data in terms of randomized trials to support the use of beta blockers. Midodrine is also very difficult as a long-term medication, but is sometimes helpful. Some of the best data in randomized trials is actually just for SSRIs, particularly paroxetine, fluoxetine, and sertraline. Disopyramide can sometimes be helpful. And then there's a little bit of data to support permanent pacemaker with rate hysteresis, but it's largely been shown to be ineffective in randomized trials. So age considerations, the elderly. The elderly patients, as we looked at the beginning of the talk, have an increased risk of syncope. They're more likely to have heart disease, cerebral vascular disease. They're also more likely to be on medications that lower their blood pressure and that can make them have orthostatic decreases in blood pressure. So beta blockers, diuretics, ACE inhibitors, ARBs, alpha blockers, and calcium channel blockers. Medications that they take can also aggravate their bradycardia, particularly if their renal function changes or something else happens to them clinically. In younger patients, reflex-mediated syncope is much more common. It can rarely even be seen with SVT or idiopathic VT, so when patients go into their tachyarrhythmia, they then have reflex syncope and have syncope more because of the vasodilatation than the actual heart rate. Drug abuse, cocaine, myocardial ischemia, arrhythmias, methamphetamines can produce arrhythmias, methadone can produce polymorphic VT due to QT prolongation. Family history of sudden death is very important, premature coronary artery disease, and familial sudden death syndromes. I think it's important for us to all keep in mind that when we think of sudden death in patients who are young, in their 30s, we often think of anomalous coronary artery diseases or congenital heart disease as a big cause. But when we look at a relatively old now series of patients where we looked at autopsy data and people having sudden death before the age of 35, it's important that coronary artery disease and myocardial infarction is still at the top of the list. So even though a patient is young doesn't mean that they can't have a myocardial infarction or coronary artery disease. So syncope in patients with non-ischemic dilated cardiomyopathy has been demonstrated to have a high risk of sudden death despite a negative EP study. There have been a number of studies now that have looked at how well we can determine post hoc what the cause of syncope is once the EF is low. And now in the ICD guidelines for patients with non-ischemic cardiomyopathy and syncope, this is an indication for ICD implant. So those patients should be taken very seriously. Paroxysmal supraventricular tachycardia is covered in another talk, but often patients clinically will have sudden onset and offset of rapid palpitations. Onset is commonly in childhood or young adulthood. It's usually not associated with structural heart disease, but it can cause severe symptoms. As we mentioned before, some people will get a vagal reaction when they get their SVT episode, which can cause syncope. And then there's a rare risk of sudden death if Wolff-Parkinson-White is evident during sinus rhythm. So if you see a delta wave, which is a slurred complex where the PR interval is extremely short and the QRS is a bit broad, you can see a delta wave from ventricular activation from the accessory pathway, and that could convey a risk of sudden death due to atrial fibrillation with rapid ventricular response, and that's an important cause of syncope in the young. So let's look at some familial syndromes associated with syncope and sudden death. Hypertrophic cardiomyopathy, congenital long QT syndrome, arrhythmic right ventricular dysplasia or right ventricular cardiomyopathy, Brugada syndrome, and then others, familial dilated cardiomyopathies, congenital heart block, and catecholaminergic polymorphic VT or CPVT. So here's a question. This ECG in a young patient with syncope suggests which of the following? Hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, Brugada syndrome, congenital long QT syndrome, or familial dilated cardiomyopathy. If we look at this ECG, we can see that there are voltage criteria for left ventricular hypertrophy seen in AVL and in V2 and V5. In addition, there are repolarization abnormalities seen in V3 through V6, as well as 1 in AVL. So this is suggestive of hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy has a prevalence of 1 in 500. LVH, or repolarization abnormalities, are seen in about 85% of patients that are affected. They often have palpitations that on monitoring can be due to atrial fibrillation, and it's been recently appreciated that those patients have a high stroke risk, so we have a low threshold to anticoagulate these patients to prevent stroke, even though they may be young with a low CHA2DS2-VASc score. Depending on the type of hypertrophic cardiomyopathy, the sudden death risk can be 1 to 3% per year. Here's another ECG from a patient who's young with syncope, and we see here that the ECG suggests which of the following diagnoses. The diagnoses are the same as the previous case. So this is V1, V2, and V3. You notice that there are T-wave inversions, V1, V2, V3, and extending actually all the way out the precordium. It's pretty abnormal. And when we look at V2, very close up, you see at the terminal portion of the QRS, there's this sort of delayed conduction. And this is a sign of an epsilon wave. It's usually a sign that there's delayed conduction in the right ventricle. And this is pathognomonic for arrhythmogenic right ventricular dysplasia or cardiomyopathy. The prevalence is about 1 in 5,000. There are T-wave inversions in the precordial leads in about 85%. The disease is due to fibrofatty infiltration of the right ventricle, but sometimes also the left ventricle. The ventricular tachycardia that's seen is often of a left bundle morphology, suggesting that it's coming from the right ventricle, and it's often exercise provoked. There's an interaction between exercise and the disease, so patients often are exercise restricted. The estimated mortality risk untreated is about 3% per year. There are autosomal dominant and recessive forms, and at least 8 causative genes, quite a few more now that have been described. And they can be cell adhesion proteins, plakophilin, plakoglobin, ryanodine receptor mutations, and TGF-beta have also been described. So here's another young person with syncope, and this ECG suggests which of the following. The abnormalities here confined to V1, V2, and V3, and this is manifestation of Brugada syndrome. So to diagnose Brugada syndrome, you have to have ST elevation of at least 2 millimeters from the TP segment in 2 consecutive leads. And here you can see that in V1 and V2, that this meets criteria for a type 1 Brugada pattern. So Brugada syndrome is sudden death due to polymorphic ventricular tachycardia or ventricular fibrillation. Events typically occur during sleep or fever. The average age at the first event is 41 years, though the range, as you can see, is quite wide. They can also sometimes have atrial arrhythmias and AV block. About 20% have a sodium channel mutation in SCN5A. There's a male and Asian predilection. There's also a Mediterranean predilection. The risk of cardiac arrest is approximately 10% per year. It may be substantially less if no arrhythmia symptoms are present at the time of diagnosis, and an implantable cardioverter defibrillator is protective. Here's another ECG in a patient with syncope. This ECG suggests which of the following. This one isn't very subtle. You can see the QT interval is massively prolonged. This patient turned out to have long QT type 2. So this is congenital long QT syndrome. And these are usually mutations in genes coding for cardiac potassium or sodium channels. They have autosomal dominant and recessive forms and variable penetrance. The presenting symptoms can be syncope or sudden death. And the ECG usually shows a QT interval that's greater than 460, but also with abnormal morphology. And the arrhythmia that they're at risk for is torsade de pointe. Here you see QT prolongation with delayed after depolarizations and torsade. So in summary, when dealing with a patient with syncope, the history of the event is very important. The goals of the cardiac evaluation are to detect structural heart disease and assess risk for sudden death. Appropriate use of ambulatory monitoring in lower risk patients is indicated, and family screening for those with detected syndromes is extremely important.